go around and introduce the Budget Committee. I'll come to order. I am Tim Brown, House District 41, Chairman of Ways and Means, Chairman of the Budget Committee.
My name is Ben Cooley. I'm the Director of Fiscal Policy for the House Republican Caucus.
Good morning, Zach Jackson. I'm the Governor's Budget Director.
Hi, I'm Joe Habig, Deputy Budget Director.
Lisa Ackelbert, Deputy Budget Director.
Ms. Brown, State Senate District 15, Senate Republican alternate, thank you.
Seth Hinshaw, Fiscal Analyst for the Senate Republican Caucus.
Bob Cherry, State Representative, District 53, alternate House Republicans.
Liza Bartlett, Fiscal Analyst for the House Republican Caucus.
Carrie Hamilton, State Representative, House District 87, House Democrat alternate.
Greg Taylor, State Senate District 33, Senate Democrat alternate.
Susan Preble, Fiscal Analyst for the Senate Democrat Caucus.
District 4, Senate Democrat Caucus.
Eric Gonzalez, House Democrat Fiscal Analyst.
Representative Gregory Porter, Indianapolis, House District 96, Ranking Member Ways and Means, Voting Member Budget Committee.
Krista Ricci, Senior Fiscal Analyst for the Senate Republican Caucus.
Ryan Mishler, Senate District 9, Appropriations Chair.
Thank you, everybody. The minutes of the last meeting, the August meeting, have been distributed. Are there any amendments to the minutes? Seeing none, can we have a motion for the minutes?
I have a request. When I review these minutes, when we have conversations with those who are presenting, like requests for information, would it be possible to have those requests reflect in the minutes henceforth? There have been several occasions where we've asked for information, never get the information. It's not reflected in the minutes. And just wondering if that would be something that we could do here on the Budget Committee to reflect questions or requests that are promised to us that are never fulfilled. Thank you.
Thank you. We'll try and reflect that as best we can possible. It's been moved and seconded to accept the minutes of the last meeting. All those in favor say aye. Aye. Opposed, nay. The minutes of the August meeting are adopted. We'll then go to the September agenda. There's been a proposed agenda that's been distributed to all members and released to the public. Are there any amendments to the proposed agenda? Seeing none, we'll go through the agencies and agenda. First, we have the Department of Corrections, Mr. Orm.
Thank you, Mr. Chairman and members of the committee. Good morning. The first project that we have for your consideration is a roofing project at Plainfield Correctional Facility. The current roof on the two structures are 33 years old. They have a total roof space of 85,000 square feet. Two simple housing units in the heart of the facility. We anticipate these will be in service for the foreseeable future. The rest of the structures are in impeccable condition. It's a good investment in the people's money. They're just at that point in their life cycle where the roof requires replacement.
Questions for Mr. Orm? Senator Brown.
Related to, because you've come before us with these roof repairs, so I'm wondering if the number of inmates has significantly reduced due to COVID release, what that is, what your capacity is now, and if you see that is a permanent fix going forward such that some of these facilities could be downsized.
Ma'am, I'm the construction guy. I'm probably not the best one to speak to capacity issues, but our legislative services group will have all that information, and I will absolutely have them contact you and provide that. I get a monthly or a bi-weekly briefing on offender capacity. Our capacity is down. What the plans are for the future of some of the facilities, I could not comment on that strategy, but I will absolutely have Margot Auxerre contact your staff and give you some insight into that.
Thank you.
Further questions? Thank you. Next project?
The second project is a little bit unique. It is the replacement of some underground high-voltage transformers. It's a pretty unique project. 50, 60 years ago, they would take pole-mount high-voltage transformers, put them underground, where several state agencies that I've seen these over the years, from National Guard armories actually to prisons to state hospitals. It was a unique design concept of the era. It probably saved some money back then. In today's world, OSHA is not terribly happy with the energized high voltage lines that run exposed to the bottoms of our prison. These have reached the point of both 42 years of age, being ready for replacement, and also to clear up the OSHA concerns with staff safety down in those tunnels and the distribution of electrical energy. This project provides all engineering and materials to replace those transformers.
Questions? Thank you.
Thank you, Mr. Chairman.
Thank you. Mr. Smith with the Department of Natural Resources. Good to see you.
Good morning, everyone. DNR has 3 projects on today's agenda. The first being the Velonia Nursery emergency roof repair. DNR is requesting $317,000 to repair the roof that covers the nursery cooler that stores seedlings. The facility was constructed in the 1940s, and the last repair to the roof was over 20 years ago. The roof is approximately 6,250 square feet and received substantial damage during a storm earlier this summer. Velonia is one of our 2 nurseries run by our forestry division. Jasper Pulaski is the other. These 2 nurseries generate over $700,000 in revenue annually.
Questions? Senator Talion.
Insurance on any of this stuff?
No, we do not.
Why-
Self-insured.
You're self-insured on all
Yes.
these buildings?
Yes, we are.
Thank you.
You're welcome.
Further questions? Representative Porter.
Thank you, Mr. Chairman. Mr. Smith, the question I have for you that I've had on numerous occasions is about the MBEWB participation on most of your projects. That's going to be a blanket question. I've been waiting for a while to get information back from you in regards to that I publicly request and haven't gotten it yet. So I'm going to again ask you about the participation goals or vendors that you have in regards to DNR. Hopefully, we'll get that information sometime during this century. Thank you.
I would like to respond to that. I believe you may be referring to that request when we had the deferred maintenance agenda item, possibly, gosh, that was last September, so I guess it was about a year ago. And we worked with the IDOA and did provide that information to you, I believe, and I will follow up again on that.
Thank you. Next project.
Yes, the second project is State Parks General Rehabilitation. DNR is requesting $1.5 million for general rehabilitation of its many facilities and structures. Maintenance and repairs would include HVAC equipment, roofing projects, window and door replacement, trail construction, et cetera, et cetera. Last fiscal year, State Parks generated close to $34 million in revenue. I would like to add that the parks and the reservoirs are still going gangbusters this summer and throughout the recreation season. Admissions are up over 20%, camping's up over 40%, and we're just having a heck of a year.
Questions? Thank you. Next project.
Our third and final project is the Turkey Run Inn mold remediation. DNR is requesting $525,000 to address mold issues located on the 3rd floor of the Turkey Run Inn. The 3rd floor consists of 9 guest rooms, It is believed that mold developed due to a substantial roof leak that was recently repaired in 2019. The inn celebrated its 100th anniversary in 2019 and generates over $3 million in revenue annually with a 63% occupancy rate.
Questions? Thank you.
Thank you.
Department of Administration, Mr. Kent.
Thank you, Mr. Chairman. Matt Kent, Department of Administration. I'm here this morning on behalf of the Indiana State Library. A few years ago, I came before this committee to request funding for the State Library roof, and we have just finished up work on that roof, and that was the kind of the first phase on sealing the exterior envelope of the building. So now that that roof is done, we need to move down to the sides of the limestone exterior of that building. So currently there is still some moisture and water that's coming in from the limestone facade of the building. We're starting to see we're still seeing some of the water staining and some of the moisture on some of the ceilings, and then some of the interior walls are still seeing the water staining. So eventually that will lead to mold and then interior damage of the building. So this project will be very similar to the work that we're seeing on the State House that's just now wrapping up. So we'll address all of the limestone blocks, we'll inspect those and repair them where needed, and we'll replace all of the seals on the building to make sure that we've got a watertight envelope on the building. Once that work is done, we should be able to maintain the facade of the building with the preventive maintenance schedule. So similar to State House, we're going to do this work in phases. So you'll be seeing a request in the capital budget for fiscal 22 and 23 for $2 million, I believe we've got it in there for right now. And so once this first phase is done, we'll come back and continue the work on it in fiscal 22 and 23.
Okay, so the next budget, there'll be phase 2.
Correct. Yep. We hope it's not as many phases as the State House was. So.
Okay. Questions for Mr. Kent? Thank you.
Thank you.
Next is Mr. McAvoy for the Department of Transportation.
Morning, Mr. Chairman, members of the committee. NDOT has 3 projects. The first one is we formally request funding in the amount of $846,050 for 21 various repair and rehabilitation projects across our 6 districts. All 21 projects have met their expected life expectancy or correct a serious operational deficiency. The request consists of 6 roof replacement projects: Columbus Subdistrict, Fort Wayne US 27 South Construction Field Office, Wabash Construction Field Office, North Vernon Salt Dome, Crisney Unit, and the Chandler Unit. We also have 2 HVAC replacement projects. Indianapolis Subdistrict has HVAC controls that need replaced, and we need to replace the boiler at our LaPorte testing building. There are 13 miscellaneous projects also included. We have the Crawfordsville Traffic Emergency Generator replacement, the Lisden Unit Secondary Containment replacement, Elkhart Subdistrict Incinerator replacement, Elkhart Subdistrict Well replacement, Fort Wayne Unit Wash Bay Concrete Floor replacement, Newcastle Unit Fence and Gate replacement, Rushville Unit Fence and Gate replacement, Greenfield Subdistrict Vehicle Lift replacement, Albany Subdistrict Lift replacement, Monticello Subdistrict Lift replacement, Seymour District Secondary Containment Expansion, Falls City Subdistrict Lift replacement, and another Seymour District Lift replacement project.
Questions? Thank you. Next project?
Next project we are formally requesting funding in the amount of $4,725,000 for the construction of a 7,000 square foot unit building and a 15,475 square foot or 3,500 ton salt building in Waterloo. This new unit building will replace the existing 1,800 square foot unit building that was built in 1968. And the new salt building will replace the existing salt dome that was built in 1984. Both buildings will be constructed on the existing site. The existing unit building does not allow for OSHA-approved work clearances or proper ventilation within the garage space. In addition, the age and condition of the structure has contributed to operational and environmental issues such as ADA accessibility, the inability to wash trucks inside with containment, site drainage, and stormwater runoff issues. The existing salt building does not allow for salt to be offloaded and loaded under roof and out of the weather. Offloading and loading of salt outside in winter weather is unsafe and contributes to on-site salt contamination. Construction of the new unit building and salt building will mitigate these concerns while keeping in line with the current industry standards of pricing for similar NDOT unit and salt buildings.
Senator Brown?
My glasses fogged up, I couldn't do the math. So in the Waterloo unit, it looks roughly like it's about $200 per square foot construction. This is half of that. Why is there such a significant difference?
A significant difference from which project?
The Waterloo one to the one you just discussed in Greenfield.
So the one I just discussed was Waterloo.
No, the Waterloo is 4 million, right?
Right. So both projects combined equal $4,725,000. The salt building is included in that. Both buildings are included in that price.
Okay, so I'm sorry, I jumped ahead. So, but you have $200 roughly per square foot, it's about $214. Why is that industry standard for that? That seems rather high, but I don't.
It's definitely industry standard. Sometimes we see anywhere from $185 to $250 a square foot for these types of buildings. Salt buildings we can get built for much less, because there's non-occupied space there. But that's the typical square foot pricing that we're seeing right now.
Okay, because then I'm going to hold my next question because the next project is half that. All right, thanks.
Is the location of this Waterloo building important for the Transportation Department?
Yeah, it's an existing unit site, which has serviced, NDOT for many, many years, right? It's adjacent to I-69, right? So it services a large section of I-69 and the surrounding state roads. Utilities are available there. It's a small site, but anytime we feel like that we have a current unit site, that meets our needs, we would like to stay there if all possible. So that's one of the reasons why we're going to stay there as well.
Okay. Further questions? Next.
Final project is requesting funding in the amount of $1,400,000 for the renovation of the Greenfield traffic building into our new statewide sign shop operations. The existing 6,668 square foot Greenfield traffic building was built in 1983, and the current statewide sign shop operation is located at the IDOA Logistical Support Center in Indianapolis. Recent renovations to our Greenfield testing building will allow for the staff currently located in the traffic building to be relocated to the testing building. This will free up traffic building for the new sign shop and allow us to relocate our sign making operation into our own facility and consolidate operations with the Greenfield district. In addition, our vacated space at the LSC will allow IDOA to repurpose it for other agency use. The project will add approximately 4,000 square feet to the traffic building, a new properly sized and code-compliant HVAC system, ADA-compliant restrooms, and other necessary upgrades to the building's mechanical, plumbing, and electrical systems.
Senator Brown?
The space you're vacating, what is that going to be used for again?
So the building as it sits now houses some traffic employees. It's basically a large, used to be a storage structure. So a prior project that I had presented to the Budget Committee was renovation of the testing building, which is on the same property. We're going to move the people that are currently in the traffic building over to the new, redesigned, renovated testing building. That will open up the entire square footage in the traffic building for use of our new sign making operation.
And then the sign making, that was my question.
Yeah, then they're going to move out of the LSC to this Greenfield traffic building. and consolidate some sign-making operations with the Greenfield district.
Right, but the space the sign-making group is leaving, what is that space going to be used for?
So IDOA owns the facility, and I believe they have an intention to bring in the Department of Health for the square footage that we're vacating at the LSC. You'd have to talk to IDOA.
Okay, thank you.
Here, yeah, this facility that they're leaving, the traffic, or pardon me, the sign operations, that is on East 30th and Shadeland. It's an IDOA owned and run facility. We've got State Archives Record Center there. NDOT has a presence there. I think there's even a DOC presence there, or Community Corrections or something like that.
Yep.
But it's a big facility, the IDOA.
That's correct.
And the intent is to, the health department needs some storage space. And that's one of the reasons to pursue this project. But at the end of the day, health department's going to occupy that space.
For storage.
For storage.
Thank you.
Further questions? Thank you.
Thank you.
Very much.
Appreciate it.
Next, we have Brigadier General Lyles.
Good morning, Mr. Chairman. Good morning, committee. I'm Brigadier General Dale Lyles, the Adjutant General for the Indiana National Guard. This morning, I want to start by recognizing the fiscal pressure that the state of Indiana is under due to the coronavirus pandemic. And certainly, I appreciate the hard work of this committee. Additionally, I recognize my agency's responsibility and need to be fiscally and financially responsible during these difficult times. After thorough staffing and review by our facilities engineer team for our sustainment, restoration, and modernization requirements, I'm here today to request $1.6 million for necessary maintenance projects, as well as a state match design fee for our new Armory project. These projects come with $2.7 million in federal match. And lastly, IDOA Public Works bid guidelines are strongly considered with all of our projects. These projects are outlined in the Budget Committee agenda and include boiler replacement at the Gary and Hammond Armory, roof replacement at Madison, South Bend, and Gary, and a design for the Hamilton County Armory. The first project is $646,924, and it encompasses roof projects, again for Madison, South Bend, and Gary. All three of these armories have reached their useful life of roof design. The new roofs will have 30-year life expectancies.
Questions? Senator Talion?
This is just for my own information. What are these armories currently used for?
So these particular armories, as well as all of our armories, come with an arms room where we store all of our weapon systems, as well as all of our supplies. They also represent a facility whereby our soldiers and airmen come to start their drill assembly. Today, many of these armories are being used as test sites by the Indiana Department of Health for the COVID testing. And they're also offered to the community to rent at a very marginal cost.
Any further questions? Thank you. Go ahead.
Our second project is for $329,033, and it consists of boiler replacement in our armories at Hammond and Gary Armory. These boilers are 30 to 34 years old, and they continue to fail, and we are unable to provide hot water and heating for those two facilities.
Questions? Go ahead, sir.
Lastly, we request $579,780,000 for a center design fee for the new Hamilton County Armory project.
Questions? Senator Taylor.
Thank you, Mr. Chairman. The project, it's going to be in Hamilton County?
Yes, sir.
All right. Because it's in Hamilton County, I wanted to ask you a question. Do we, and you may not know this question, but do we pay property taxes on that facility?
I do not believe that the state pays property taxes.
On that facility?
Yes, sir.
So there's no pilot or anything that's going to be
No what?
Payment in lieu of tax?
I'd have to defer to Zach. I don't believe so, no, sir. Being a state agency, I would say not.
Okay, thank you.
Is not taxable.
Yeah, I just wanted to bring that up because a lot of people don't have to pay taxes. I mean, the statute doesn't provide that they do, but they can pay what's called a payment in lieu of taxes. I just wanted to make sure as well.
Yeah, but my only experience with PILT or pilot is from the federal government, them passing along some dollars to the state where we have like large national forests or something like that in some of our rural counties. But in terms of the Guard, I'm not aware of them paying any tax. Yep.
Thank you. Thank you.
Senator Brown.
On that lines, you're going to result in about the same amount of square footage. So I assume there is a reason why you need from three smaller armories to have this size, but also what happens to the three smaller armories now that are in different locations?
Yes, ma'am. There is a protocol that we follow, and that protocol is that first we offer those armories back to the IDOA, then it transcends down to the local government, and if no one is willing or wants those armories, then we wind up offering them at public for bid.
So those three existing properties could potentially end up back on the tax rolls, or not end up back, but be on the tax rolls.
That's correct. They would follow that protocol of whether or not we wanted to accept them or accept them back into the state agency or go back into the local agencies as well.
All right, thank you.
Further questions? Thank you. Anything else?
No, sir. Thank you.
Thank you very much. That concludes our project. We'll next go to our review items. Ms. Taylor?
Good morning. My name is Allison Taylor. I am the Director of the Office of Medicaid Policy and Planning within FSSA. I have a handful of review items for you today. If it's all right, I'll just start through those. The first one is our Tobacco Cessation State Plan Amendment. So this changes the reimbursement methodology for tobacco cessation drugs, the requirements for all fee-for-service Medicaid members. We're making this change to increase access to tobacco cessation drugs, to decrease use of tobacco products in Indiana. And there are approximately 9,000 fee-for-service claims annually for members using these drugs, and so those are the ones that would be impacted at about $3 a copay. There's a small fiscal, and I just want to note our managed care entities have been waiving this copay, so it's just impacting fee-for-service and effective retro to February 1st, 2020.
Questions? Thank you.
Okay.
Continue.
Thank you. Next, I have I'm excited to present a opportunity. It's an 1115 public health emergency demonstration waiver. So just a little bit of context here. FSSA and the Department of Health convened a work group over the last couple of years to really promote long-term services and supports, integration, and foster aging at home. One main point, and really a major pain point identified by this group, was the disparity in timelines for accessing home-based care versus nursing facility care. And to get home-based care, it can take weeks to go through two eligibility processes, both functional and financial, while the transition to nursing home can occur quite quicker. So this stakeholder group really issued a call to action to get home-based eligibility to less than 72, maybe even better at 48 hours. That is a huge undertaking, and our teams have been working on that solution. But COVID, the public health emergency, actually brought to a unique opportunity for states to pursue some emergency authority that would allow faster access to home and community-based services. So for those that are at risk of hospitalization or nursing facility stays due to COVID. So a real high-level summary of this opportunity essentially would allow immediate Medicaid coverage and A&D waiver coverage for those 65 and older deemed likely to be eligible. So our team has created an expedited eligibility determination process, involves self-attestation on the front end and auditing and post-approval verification on the back end. And coverage would start the first month of application, and approval would last 12 months. This pilot would be effective October 1st, 2020, and would last, I think this is an important point, it would only last 60 days past the end of the public health emergency, so really just an opportunity for us to try out what this expedited process looks like. We have a very targeted pilot set up. 5 providers will help us engage in different parts of the state working on this expedited eligibility process. And we're really excited about this opportunity.
Senator Taylor.
Chairman. Ms. Taylor, I'd like to, what is the process to come up with the criteria for this expedited decision making?
So it's the same eligibility process, both functional and financial. So to get, and when you're at the point when you need assistance with daily activities and you're eligible for LTSS, you have to go through a financial component, which is the Medicaid, and then on the waiver side, also assessing those needs that you have for assisted, the daily living needs. And so the parameters don't change. Ultimately, the fiscal is so small because we are honing in on those individuals that we are pretty darn sure that they were going to get in the program no matter what. We're just working on getting them there a little quicker. So we're not changing any of the parameters to get these services. We are just targeting folks that we know against all odds they're gonna be eligible and they're gonna be in, and we're just gonna see what happens when we get them there quicker.
Okay. You said you haven't changed any eligibility, but I think I heard in your testimony you're only focusing on those who are 65 and older.
Mm-hmm.
For waiver services, you could be 2 years old. So if your pilot is only focusing on 65 and older,
It is.
then you have changed the criteria for the waiver, because the criteria has an age requirement.
Well, so we're targeting those A&D 65 and older, so a population that we're trying to get in the home, divert from nursing homes. So we're looking at, it's got to be at risk of impacts from COVID too, so that's sort of the uniqueness of this public health emergency opportunity.
Which
That
goes
makes
to
sense.
my other point.
Okay.
Comorbidities is probably the most prevalent factor when it comes to complications with COVID. And that could be with someone who's younger than 65. So why wouldn't you focus on those people who have comorbidities instead of making it an age requirement? My concern is this. You're doing a pilot, which I would assume that you would have, the pilot would show you what the effectiveness of this program would be, and then therefore you can make a decision going forward. But if you don't pass that down or have a full scale, you know, you could have some eligibility for people younger than 65 who are homebound and need services as well. I'm just concerned about just focusing on people older than 65 when we know that comorbidities could be somebody who's 30. So I'm a little concerned about the pilot and the fact that you did change the criteria, because the criteria doesn't require you to be 65 again. It does require you to have be eligible. So I'm just a little concerned about that. It may be successful, but my concern is that you've only focused on people over 65.
Okay. I think, would the secretary like to, come on. Is that okay, Chairman?
Yeah.
Okay. And
Senator Taylor, thank you for bringing up those points. So first of all, just to come back, the A&D waiver itself has not changed criteria. So there is no age restriction or limitations on individuals who will qualify for that waiver as it exists. Because this is a public health emergency, we needed to base our application on the data. And so the data that we have is the highest risk individuals are those who are over 65 with comorbidities and in congregate settings. So those are nursing facilities. And so this pilot is specifically designed for the highest impact to the most at-risk population. So we've not seen that same morbidity and mortality in younger individuals, even those with comorbidities. So again, unchanged A&D waiver criteria for the existing person. This pilot program will be, if approved, October 1st, 60 days past the end of the public health emergency, to give us data on whether this process works. And if the process works, then we get to do it for a larger group. But we really wanted to have a high-impact, high-yield program that we could do our due diligence for learning on whether an expedited eligibility process will work for the highest-risk individuals under the public health emergency.
Yes, I think we would just have to agree to disagree on I think comorbidities, which are actually the people who are at highest risk. 65 and older typically have more comorbidities. Therefore, that's why, they are in the higher risk category. But I'm glad to hear that the basic plan has not changed. Going to your point, to be able to compile the data and go forward with, you're under the impression that this would allow us to expedite more people on the correct me if I'm wrong, did you say you want to be able to use this pilot and the data to actually speed up the process?
That gives us the ability to talk about what that might look like for an expedited process for the future. We wouldn't do anything for a pilot if we didn't intend to learn from it and do something about it.
That's what I was focusing on.
That's exactly right.
Yeah, so that's why I was wondering why under the regular program there's no age requirement. Kind of goes to my point. Why wouldn't you include those? I mean, there could be some kids who are in their 30s or younger that have comorbidity. My only fear is that when you do go back to request to change, if you can, that after your data is collected, they're going to say, well, your cohort was only 65 and older, so why do you want to change it for the entire program? That's just my fear. I could be wrong. I just think that we would do better if we included just a few, if not half of the people who might be eligible.
So from a clinical and COVID perspective, in this particular case, we want to make sure that we, one, put in an application that will be approved. So this looks exactly like an application that was approved through Washington State.
You have to say no more.
Okay. Thank you.
Thank you, Dr.
Thank you, Mr. Chairman.
Thank you.
Continue.
Okay.
Oh, Senator Talion, I'm sorry.
Couple questions. First of all, can we use CARES money to pay for the state portion of this?
Can we use what?
CARES money?
Defer.
No.
Okay, all right. And the other question is, what areas of the state are you looking at?
So I have a list here of Marion, Morgan, Johnson, Shelby, Hancock, Hamilton, Boone, Hendricks, Scott, Clark, Floyd, Harrison, LaPorte, St. Joseph, Elkhart, Marshall, Kosciuszko. And those are going to be, we actually are 5 providers that would cover those geographic areas.
Further question? Continue.
Okay, thank you. The next is a state plan amendment for our behavioral and primary health care coordination, SPA. And so this change makes 3 basic changes. 1, we are clarifying that members can request additional services as needed. This is to comply with the Mental Health Parity and Addiction Equality Act. 2, we are making a change. This SPA actually references community health worker, which over the last couple of years, as you know, Medicaid has really adopted that as a larger vehicle or vessel for delivery of services in the community. So we are, within this section of the SPA and in this program, renaming that community health worker, and we've got a different name now. It's integrated health technician. Finally, we are making a change on post-degree requirements from 3 to 2 years of experience working with individuals with serious mental illness and substance use disorder. That was recommended by the professionals in our agency and industry. So those are the 3 changes that we're making.
Senator Brown.
2 to 3 years or
They're going
less than?
from 3 to 2. So yes.
Okay. And I have heard from some providers that are maybe nationally, I'm not sure if they know statewide, our mental health usage is up 41% due to the COVID partly. Are we seeing that with usage in the now called, is it behavioral health technicians? Is that what you said?
I don't know if I've done the analysis of, if we have the analysis of these technicians, but we do know generally the need for mental health services, particularly at this time, has risen. And so we'll talk in a minute about a couple of changes we've made in our policy to telehealth to really try to meet growing need.
Okay, thanks.
Further questions? Continue.
Okay, thank you. Next, we have a state plan amendment regarding durable medical equipment. So this state plan amendment is a result of a change in federal law. The Cures Act instructed states that they may not pay above what Medicare pays in aggregate for certain DME codes. What this means for states is that they essentially owe federal financial participation or match back on any of the overage. It turns out that in Indiana, we were paying over Medicare, sometimes substantially above what Medicare pays. And so this definitely puts states and industry in a difficult position. Understanding local providers and national DME groups expressed concern with these changes. We tried to come into compliance in 2019, but pulled back to give industry a little bit more time to adjust. However, we're now at the point where we really do need to come into compliance. We can't afford to be on the default side anymore. And so this state plan amendment sets the stage for ultimate compliance scheduled or slated for February 1st, 2021. You'll see that this results in some savings annually. What you see below is prorated. I think, Joe, I think I owe you an answer to a question. You asked, what would the, once we gear up, what would a full state fiscal year of savings be? It's about $3 million total savings, federal, with a state share impact of around $1,010,000.
Questions? Zach?
Allison, prior to kind of, I guess, going to the Medicare rates, what was the basis for our reimbursement for DME?
Gosh, we had a schedule that we worked with our rate-setting contractor, and I can tell you what we're moving to, which is based on Medicare. I think we had sort of a different, bit more customized, and I really can't go too much more in detail because I'll say it wrong. But I think the idea is to align with Medicare and have kind of a predictable annual look at what rates are.
Further questions? Continue.
Okay. Next, we have an 1115 waiver for Maternal Opioid Misuse Indiana Initiative. So this we call the MOM grant, and it's really has two streams to it. The first and larger piece is that we competitively applied to CMS to get funding to assist with infant and maternal mortality. We were one of a handful of states nationally that actually received the bid. And the larger goal of this grant is to assist pregnant and postpartum women with opioid use disorder. Key goal of getting them buprenorphine treatment, which is associated with less relapse when it's taken long enough, at least 12 months. And so a critical component to meet the purpose of that grant would be for us to extend Medicaid coverage for moms postpartum to 12 months to match that period of coverage. And so you will see it's a relatively small number of women in this pilot. We're estimating about 60 women, but for a slight cost, we think there will be potentially tremendous savings for if we can prevent some neonatal abstinence syndrome and other negative impacts. So we're really excited about that opportunity.
Question? Senator Taylor?
First of all, thank you.
Hey, you're welcome. I want to recognize that I think there were a couple legislative, so thank you.
I want to focus on that. Several years ago, I brought to the attention, I believe, the I'm so sorry. I should know your name. But anyway, I brought up the fact that if we took care of just the disproportionate share of minority women associated with postpartum depression, we would move into the top category of states for infant mortality. And this pilot program could be the impetus for that. So because I'm focused on, forgive me, but the disproportionality associated with women of color, how many of these women are going to be of color?
It's a great question. I don't know that we have that demographic broken down.
Please do.
Okay.
I'm
Absolutely.
just asking because I think if you do that, you will see the impact, or at least be able to collect the data on the impact to the state of Indiana. In addition, you talked about savings. Can you explain that to me? Savings from doing that?
Yeah, so what isn't captured here, but what the theory would be that, you know, you prevent babies being born with neonatal abstinence syndrome alone is costly and terrible. So and then there's other positive health outcomes too. So,
including the postpartum depression and
sure,
other things
depression,
associated with
maintaining treatment, no relapse, no hospital stays.
that the state ends up
Yes.
picking up because these mothers typically are on the Medicaid rolls and the children are probably on there too.
Right, these would be Medicaid eligible women, so yes.
Right. So, just to reemphasize,
I hear
this
you.
is very important that we look at the disproportionality in the minority community.
Yeah.
And deliberately do that, because if we don't, we will not be able to take care of what I think would be a benefit to the entire state of Indiana. Thank you for this.
No, absolutely, and I want to say, I hear you. We are, as an agency, really focusing under the secretary, under her direction, to really, really drill down on deliberate impact on minorities. So we are there with you and look forward to infusing that in what we do. Further infusing, yeah.
Senator Talion?
Thank you. You're calling this a pilot, and you said is it only being limited to certain areas, or is it capped by a certain number of people, or can you explain that?
Sure. It is a pilot in the sense that I guess I should call it more of a grant, right? So we've got a window, we've got a couple of years of build up, so we're doing the infrastructure. The grant covers the administrative work that goes to kind of set up this process, but again, we got to get the coverage to complement the work that we're doing. And I think it's a couple year opportunity, 2 to 3 years. And so that's the period of it.
And is this limited to a certain number of people? Is it not limited? I mean, can anybody use it? And is it directed to particular areas of the state? Or can it be used anywhere?
Okay, Secretary, this is, she may have some expertise. I'll let you go.
Thank you, Senator Talion, for your question. This pilot is the policy. It doesn't have a limitation based on geography or number cap. It really is setting up the infrastructure for longer coverage under if a woman is Medicaid eligible and is on one of our managed care programs that covers pregnancy and has a substance use disorder, it covers her treatment for a year instead of our current 60-day cap on that. And so it's a pilot in the sense that we're taking a population of individuals and having a enhanced policy coverage. And then this is funded through the CMS Innovations program. And so what it does is it gives us pilot data for this group of individuals to see if we make an impact on their outcomes and then the health improvement for these women. But anyone who's eligible will be able to come into the pilot, not capped by geography or number.
Okay, and so, great. So the 60 that you were talking about, that's just a historical number Okay.
standard postpartum Medicaid coverage. And so
Okay, thank you.
looking at what prolonging that will do on health outcomes and impacts for these moms.
Thank you.
Yep, thank you.
And the moms have to be willing to participate, which is what kind of, it brings the number, we're guesstimating the fiscals based on what we think with active outreach and engagement with our health plans, who we could bring in the program.
Senator Taylor, do you have a?
Just, thank you very much for this program. Can you have you thought about working with the Indiana Minority Health Coalition?
Yes.
Okay.
Jump in.
Okay,
Yes.
all right. Because, again, I want to emphasize, we need to be deliberate about this thing. Going from 60 days to 12 months, I believe, will change the outlook for the entire state of Indiana. For every child, mother, family, this is very good. I wish we could do it for more than 60, but that's a good cohort to start with. And please work with the minority, because I think they can help you with finding women who will participate.
We will. They're a really important stakeholder in this and other programs, and as you got the full body wave from Dr. Sullivan. So we are, we have a really great chief medical officer who operates at the FSSA level, who helped get this off the ground and spearhead too. So if he were here, he'd give you that feedback too. Great.
Thank you. Next.
Oh, next. Okay. Okay. So the next one is a state plan amendment. This is pretty technical. It's meant to ensure rating accuracy. And I can give you just a few sentences. Right now, nursing facilities receive a case mix adjustment, and this happens quarterly. As a part of our review, you know, we're looking to see the complexity of the patient. We take a moment in time to see, and if that person happened to be in therapy, speech, occupational, physical therapy, then we will lump that in and assume it happened that whole quarter. And so what we are doing here is adjusting that and making it more of a real-time look, and we will prorate when they were actually in therapy to make sure that our rate is more accurate and timely. And so that this is a simple sort of update in our methodology to make sure we capture the best data on what's happening with the resident. So,
Questions? Thank you. Next.
okay. So this next state plan amendment, it is a change that captures a revised distribution methodology for our disproportionate share program for our hospitals. I think the key points are, this is in anticipation of the federal dish cuts that are set for January 1st, 2021. This was developed by industry, really just adjusts it to make it equitable in their minds among the hospital participants. It did go through the HAF committee last week, and so it is here, no fiscal impact, but again, it's focused on methodology and adjusting it for what the future might hold.
Senator Talley.
Oh, thank you. So the new, is it still a pro rata share across all the dish hospitals?
I don't know if pro rata's the right, it's still a distribution based on the formula that they had established so that everybody gets a little bit, yeah. Technical
and
term.
it's my understanding that the last budget bill provided for some reduced cut to the hospitals in Lake County, and I'm not sure exactly why that was, but does this do the same thing?
I might look to Paul. I'm gonna have our CFO come up, if that's okay. He's on the HAF committee in some form or fashion.
As I recall it, in the budget bill, there was specific language, some default language in there about how that would be handled. This goes more of a prorated, that the 50% reduction. 50% of the reduction would be felt across all the hospitals, so that would include the municipal hospitals, the Lake County hospitals, and the private acute care hospitals.
And I'm sorry, the last thing you said?
Is the private acute care hospitals.
Okay. All right, do we know what that reduced amount for Lake County was about?
I'd have to look at that specifically. You know, I know overall, nationally, they're cutting the DISH program, if it goes in place, by $4 billion the first year and moving that up to $8 billion the second year. But I'd have to look specifically what that impact would be on the Lake County hospitals.
Okay, but the new formula under this will not, eliminates that Lake County exception.
Right. I mean, so what it does is basically these reductions, instead of previously the way it was set up that the Lake County and the municipals would get their full amount and then reduction would be incorporated just to the private acute care hospitals, this would spread that so all of those hospitals felt the reduction.
Okay, thank you.
Further questions? Senator Brown.
All right, so my understanding is that this anticipated reduction is coming, or came, so to speak, July 1st, 2020, unless Congress acts to delay it. That it was enacted 3 years ago, I'm sorry, under the Affordable Care Act to reduce costs. So the pain that could be felt is gonna be $12 billion? Is that correct? And so you're distributing the pain amongst all the hospitals that receive Medicaid patients?
Yeah, so it'll be split. I mean, once it gets into full force, it will go to the $8 billion, and that's nationally right across of it. So this first year, which is only half a year, would be just a $4 billion amount, and then it would be $8 billion in the full year. So in total, for an annual amount, it would be the $8 billion reduction nationally under the DISH program.
And so the point is, under the Affordable Care Act, in order to find savings, we're gonna cut the amount that we reimburse acute and the most at-risk hospitals, if you will, which we just saw through our last legislative session, talking about those critical care hospitals. They're all gonna have their Medicaid rates reduced.
Well,
Proportionately, but they're all.
Well, they currently receive DISH payments, which is disproportionate share DISH payments, which is outside of their normal reimbursement that they receive. So those payments that they receive, those supplemental payments, will be reduced as we move forward, as long as these reductions go into place.
So Medicaid rates aren't changing, the supplemental
Right.
through the DISH program based on national sort of directions.
Right,
Right.
so we are subsidizing and supporting our critical hospitals in a sense, right? In order to keep them open, and so the supplemental pay or supplemental revenue they get is going to be reduced.
Yes, through this supplemental DISH program, they will receive less funding.
And so, having gone through significant amount of legislation last year, some successful, not, on A, reducing costs, but B, trying to keep these critical access hospitals open, some who suggested that their profit margins were 2% or less, how's that gonna affect their ability to stay open? Do we know?
So, I guess complicated, right? I mean, this has been kind of a slow rolling measure. Reimbursement is relatively complicated, right? I mean, I think we've got multiple supplemental payment programs, and I anticipated the question, and I can just say we are committed to working with hospitals and industry to really get to a place where we have alignment and transparency. I think there's just a lot of work to do there, and I do know that's a punch to the hospitals, right? That is a change that is going to require some adjustments, and we're committed to really taking a look. I think the industry at large has a lot of fiscal pressures right now, so we're going to have to all kind of work together to figure out how do we get to a sustainable and stable place. And it will involve looking at the different Medicaid rates and supplemental and all the compounding factors that kind of patchwork rates. And so I hear you. I don't have a perfect answer for you.
No, I mean, I appreciate it. It's obviously at the federal level. It is just ironic that the Affordable Care Act has instituted this, and then during the middle of COVID, when hospitals, especially in the most critical care, weren't allowed to be open at all, and their revenues have completely shriveled up, literally, and this is now coming down the pike. But that's, obviously, you're managing it, not a crisis you created, one you're managing, so thank you.
No problem. We hope to not we're hoping to manage through, but I think there's also room to stabilize on the back end. I think we're learning a little bit here too, so there's
Thank you.
opportunity.
Zach?
Kind of talk about the IHA, the Hospital Association's involvement in this, and just whether they're on board and things like that?
Yeah, I can. My understanding is this was industry driven, right? So I mean, I think this is their proposal to us after they've got a collaborative process to work with within their association and their representation, and then it comes through the HAF, which they are a part of, and secretary. Does that answer your question? I mean, so yes, this is by design, sort of an industry come together and figure out how do you navigate to hopefully keep things equitable and sustainable.
Further question? Next item?
Okay. So next we have a technical waiver amendment. So this involves our Division of Aging A&D waiver, Age and Disabled waiver. You will recall, I was here probably a year or two ago talking about undergoing an update to our HCBS rate setting process. We developed new payment methodologies to promote person-centered services, financial transparency, and sustainability. Now, we were getting kind of through the final process of updating all of our documents and realized we missed 3 rate tables that should have increased annual limits from 500 to 1,000 for 3 items that are mainly involve like improvements to your home for accessibility, like ramps or vehicle modifications. So this is a correction to really fix our error and not documenting that appropriately in the waiver. And it will go back retro to February 1st to cover kind of what we had missed.
Questions? Thank you. Next.
Okay, and this last one is a disaster relief state plan. So this is kind of a newer experience for our Medicaid team, and it captures the changes that we have made in response to the public health emergency that touched or impacted what was already in our state plan with the federal government. And we are required to, in a really expedited fashion, capture the changes that we've made and put them in the state plan. So this includes cost-sharing modifications, our telemedicine adaptations, some pharmacy changes, and our nursing facility rate add-ons. And 2 of those 4 that I mentioned had fiscal impacts, and that's why they are captured in this document. And that is the cost-sharing modifications. So again, that was waiving HIP, pharmacy copay, power account contributions, CHIP, MedWorks, et cetera. And then also the nursing facility enhanced payments as a part of our COVID response. Largely federal share, very limited state share impact. The telemedicine and the pharmacy alterations did not have a fiscal impact, so they're just capturing some policy changes.
Questions? Thank you.
Thank you.
Thank you very much. We've had discussion of construction and agency projects and review items on the agenda. Are there any motions to remove items from the agenda? Seeing none, can I have a motion to adopt the agenda? Yeah, we'll go. It's been moved and seconded to adopt the agenda. All those in favor say aye. Aye. All those opposed say same sign. Agenda is adopted. We'll next go to the discussion items. And we first have Family and Social Services, Mr. Bowling and Ms. Leonard.
Thank you, Mr. Chairman. Members of the committee, my name is Paul Bowling. I'm the CFO for the Family and Social Services Administration. Kathy's not going to be able to join us today. She blew her knee out yesterday, so it will just be me. from that standpoint. So I appreciate the opportunity to come before the committee just to give you a brief update on Medicaid as we go through this public emergency period. So just a few items, high-level items that we'd like to kind of go through with you this morning and touch base on. One is the enhanced Fmap that has been made available to us under the Families First Coronavirus Response Act. The second is to give an update on where we ended up for state fiscal year 2020. And then an update on the enrollment, Medicaid enrollment, and some impacts that we've seen on the enrollment as we've gone through this emergency period. And lastly, just an update on some utilization trends that we're seeing through 2020, just to give everyone kind of a feel of some of the utilization that we're seeing thus far as we go through this emergency period. So first, I would just like to touch base a little bit on the enhanced Fmap. As most of you are aware, an additional 6.2% was made available in enhanced Fmap under the Families First Coronavirus Response Act, and that went into effect January 1st of 2020. This enhanced Fmap will remain in effect until the last day of the quarter in which the emergency period ends. So currently, the emergency period is scheduled to end in October. So based on that, if nothing changed, we would continue to receive the enhanced Fmap through December 31st. In order to receive the enhanced Fmap, there is some maintenance of effort requirements. The two main requirements for the maintenance of effort are the waiving of the cost sharing. Allison just touched base briefly on those in one of her spas. And the other one is the suspending of eligibility closures. One of the big requirements that affects our enrollment, and we'll go into that a little more in detail in the next slide or so, is that to be eligible for the enhanced Fmap, anyone that was eligible for Medicaid when the emergency period went into effect must remain in Medicaid and eligible for those. So individuals that would normally fall out of the program on a monthly basis that we would see, we would not be seeing those people fall off the program, and then we would maintain their coverage over that period of time. So as we looked at the enhanced Fmap, for 2020, we received approximately $357 million in enhanced Fmap. A few areas it was utilized in. Some of that savings was passed on to providers who pay in IGTs or fees. So those would relate to providers who are paying in the state share for like nursing facility reimbursement or hospital assessment fees. So since they would be paying in the state share, and now the state share of any Medicaid payments is decreasing, they would see some savings with this enhanced Fmap. The other one of the bigger pieces here is the increased enrollment due to the MOE or new enrollment. So the additional costs around that and using some enhanced Fmap to cover that. And again, I'll touch base a little more on that enrollment that we're looking at here in a moment as we go to the next slide. And the other item would be some increased nursing facility reimbursement. Again, Allison also mentioned briefly going through some SPON waiver amendments around that. So another portion of some of that funding. So overall, as we looked at our Medicaid and where we ended for state fiscal year 2020, we ended up with a surplus of $249.5 million. And again, some of that, definitely a larger portion of that being related to the enhanced Fmap that we did receive during that state fiscal year.
Senator Taylor, did you have a question? No?
In a minute, but you want me to ask it now?
Pardon?
I will in a minute.
Okay, Senator Talion.
Yes, thank you. Sorry, I'm looking at, I just happen to have my folder, right? So I'm looking at the numbers that we received here in the July 16th Budget Committee. And I wrote down that our Fmap increase resulted in $460 million, and that we used about 210-ish for increased enrollment, and that we put some of it into the back into the general fund. So you're saying now we've got 357 million in enhanced FMAP, so, and that your final surplus amount was 249. So I'm just wondering the difference in the figures.
Right. Part of that would be, as we looked at what funding we were given by the federal government, they did an estimate on what the enhanced FMAP they would provide to us. So they did estimating based on our prior expenditures, what that would look like. When we get to the end of the fiscal year, we need to look at what our actual expenditures are and which of those expenditures are eligible for the enhanced FMAP. So as we've trued up state fiscal year 2020 and got to more true amount of what was actually available to us, the 357 million is a more accurate reflection of kind of our true expenditures and what would be eligible for an enhanced FMAP, even though the federal government actually gave us the ability of having the larger figure that you mentioned, Senator Italian, but because of the expenditures, we're not able to draw all that funding down.
Okay, so the 460 that we were told in July was, you're telling me was just an estimate, and this represents the truer, a more accurate amount? Is that?
Yes,
okay.
That's correct. Because
all right. So when you say final surplus amount for fiscal year 2020 was 249, what does that mean?
So what that basically means is, as you know, as we close out the Medicaid at the end of each fiscal year, we look at the appropriation we have available to us for the Medicaid assistance, and then look at our actual spend, and then the surplus would represent any state general fund funding that we still have available at the end of the fiscal year that was not utilized for Medicaid expenditures.
All right, so let me just get this right then, Zach. So the 250 that we basically plugged into the budget is this number right here?
That's right.
So we're pretty much right on?
At the end of fiscal 20, we reverted $250 million state match from Medicaid, and that's, so essentially Medicaid at the end of FY 20
is good,
Yeah,
okay.
right.
And so how much of this amount, all right, so that's about $100 million difference. So how much of that amount then went to actual enrollment increase? Is that the extra amount?
From that standpoint, so no, there is an amount, and I don't have that amount in here. I apologize from that standpoint. I do have the dollar amount. I mean, I do know of the 249.5 million, about 238 million that was related to the enhanced FMAP, and then the remaining balance would have just been the normal Medicaid surplus that we would have seen.
Okay, thank you.
Zach.
Paul, just a quick question. The initial 460 estimate, is it, am I doing my math right if I say this 250 plus the 357, so that 607 million number, is that then what did the 460 become like a $600 million number, or am I doing that math wrong?
No, the 460 did not. I mean, because initially, if you recall, like we got it by quarter. They estimated like 210 million the first quarter and 250 million the second quarter. So that was where the 460 came from. So that was the total amount that there would have been available for us to draw down on. So this is just what it is basically on actual expenditures. So you wouldn't add the two together.
Okay, thanks.
Senator Taylor?
Thank you, Mr. Chairman. All right, so just so I understand, FMAP enhancement was made available because of the pandemic.
That's correct.
Okay, and we got 357 million from the enhanced FMAP funding.
That's correct.
At that time, we had a reserve, right, for Medicaid Reserve amount. Do you know how much that was?
And when you're referring to reserve amount, I'm trying to make sure I'm,
Surplus or whatever reserve? Don't we have a Medicaid reserve?
I mean, there's a separate Medicaid reserve account that is outside of our funding, Senator Taylor, and that, so,
Yeah, we use, we use kind of the term reserve and surplus to mean several different things. So just to clarify, historically, Medicaid had some unreverted dollars on hand. We've cleaned all that up. I think we reverted the last bit of that some point last year with closeout.
right.
We also underspent because of the additional federal funding available last year. It freed up state dollars that we could revert, and so we reverted $250 million last year. That matches up with this 249.5. But then, yes, there's also the Medicaid Reserve Fund in statute. Actually, I think it's the Medicaid Reserve account, which is part of closeout. That balance of 577 million, 577.6 was moved because the general fund itself would have otherwise been negative at closeout, and so we moved the entire balance of the Medicaid reserve into the general fund so that the general fund would not close negative at the end of fiscal year 20.
Okay, so we we shored up the general fund from the Medicaid Reserve Fund. Okay.
Correct.
All
I
right.
mean, in order to be able to kind of,
Okay.
afford our
that-
appropriation.
That's good. That's good. But the last time we did that, correct me if I'm wrong, was during the recession. Am I correct?
The last
Were
time?
you here?
Yes, I was here during the, I mean,
Okay.
just barely, but yes, I was here.
Okay. So my question is, we have this surplus now, according to your record. We've got, every time there's a pandemic or a recession, the federal government provides some type of enhanced funding. We've got this. Did you receive any additional CARES Act funding on top of this, or was this considered the part of the CARES Act?
I mean, we received this, and then there was other CARES Act funding that we received for different programs and stuff throughout our agency.
So,
from that standpoint.
okay, so we did receive enhanced funding from the federal government once this pandemic hit.
Yes.
That's the point I'm trying to make. Okay. And now we have a surplus again.
Yeah, and this surplus here is actually the funding that got reverted at the end of the fiscal year. So the 250 that was pulled back at the end of the fiscal year is related to, is this surplus amount that I'm showing.
Oh, but it went to the general fund. Oh,
Right.
okay, so it's, I don't know why we're calling it a surplus. Okay.
Representative Porter, you have a...
I was going to try to help. What we did was took those 577, and plus there was our reserves, and we took the other 200 million plus, and we balanced the budget for 2020. Is that, I mean, we put it, right?
Yeah, the general fund.
Yeah, the
would have-
balance the general fund for 2020.
Yeah, so we would have
Okay.
a positive balance.
So,
in the general.
July 1 started another season of fiscal, okay? So, I was just trying to move it along because, you know, we still have some issues that's come forth. We took those dollars, because now we're essentially, what, 200 million in our reserve now, or is it completely wiped out? We had zero, right, in Medicaid reserve?
Correct, nothing.
We had nothing.
Correct.
So now we're gonna start on first base or a home plate and then try to address those dollars again, because the 200 million plus was from federal dollars that help also to balance the budget.
Yep.
Okay, so we were zero.
There is, yeah, the way I think about it, I mean, there are no old state dollars at Medicaid. We basically reverted every leftover Medicaid general fund dollar, state dollar at the end of last fiscal year. And we moved everything out of the Medicaid reserve contingency account back to the general fund at closeout.
So do you feel that we are able to continue to provide those essential services for Medicaid moving forward for new enrollees?
Yeah, so the way I
'Cause
think.
we're at zero, right?
We are at zero, but the statutory, the allowable uses of the Medicaid Contingency Reserve are basically to replenish the general fund. In the instance that the general fund does not have enough cash to make kind of full Medicaid reimbursement. And so we moved it over so that we would not have to make any reductions to the Medicaid program. Because otherwise, we would have had a negative balance at the end of the year and would have had to start talking about how we potentially make reductions to Medicaid.
Okay.
Okay, Paul, continue.
Okay, all right, so on the next slide, we just wanted to give you a snapshot picture of kind of what Indiana Medicaid enrollment has looked like through the end of state fiscal year 2020, which is June of 2020. As we've gone through this emergency period, we have seen just over 168,000 new enrollment to the Medicaid program. That is potentially, it's right around an 11% increase in enrollment from there. So again, reminder, the new enrollment is coming from two different places. This is one coming from the MOE requirements that I just talked about, that people have to be maintained with coverage under Medicaid, and then also would include a group that would be, because of the economy and people losing jobs and things of that nature, people being eligible for Medicaid and coming on the program. So as we look at this, compared to prior forecasts in that 168,000, roughly there's about 60% of those is related to the MOE requirement. So those are individuals that are being maintained on the program because of the MOE requirements related to the enhanced Fmap from there. A couple other side notes on this. The majority of the enrollment we have seen has been in our HIP program. It's been around 100,000 of that. And then the next biggest group being in the Hoosier HealthWise group from there. As we start to look into 2021, we have been looking at the enrollment, and we continue to monitor that. As we look at July and August, we are continuing to see growth in enrollment, so we are seeing increased enrollment. As we look at July and August numbers, those increases month to month have not been as large as we saw in May and June, but we are still seeing increased enrollment. We saw an increase of around another 55,000 between the months July and August from that. So again, something we continue to monitor to see as we go through the emergency period, the impact that will have on there and the use of that enhanced Fmap to cover those individuals.
Senator Italian.
So with this increased enrollment, do we have an estimate for the increased spend?
So the cost of this additional, I do not have that with me. I mean, that is something that that we could look at and we could get you those figures, but I don't know, what that cost is right now.
Well, the reason that I'm asking is because, like I said, going back to what was presented to us in July, we show, there was this estimate of 460 million, 250 went to the general fund, and it said that they were looking at approximately 210 million due in payouts due to increased enrollment. So my question is, if we've revised the total payments down by 100 million, what are we doing to the total spend?
Right.
So that's what I'm trying to figure out. Are we in the hole? Are we up? Where are we?
Right, and I think that's something that we're, like I said, continuing to monitor, because as we look at whether that we see increased enrollment, is that continuing to grow? Is it growing but not as quickly as a pace from that standpoint, to look at the funding we have available? And this is where, as we look at the enhanced Fmap and when that may or may not end for us, looking at that funding that would be available for us. But definitely happy to look at more detail around this, but I just don't have specific numbers of what that additional amount is with me today.
Okay, thank you.
Representative Humphrey. Go ahead, Kathy.
One question and a related question. Do you know if our uninsured rate, excuse me, can you hear me now? Okay. If the rate of uninsured Hoosiers has increased, and if so, how much?
I don't know what that is. No. Do we have any data?
I would assume some folks who have lost their jobs might not be eligible immediately for Medicaid. I didn't know. Okay, thank you.
Continue.
So on the last slide, I just wanted to give a brief overview of kind of utilization and some patterns that we're seeing. So if you look at this slide, we're showing different
Lines here for fee-for-service and then the three managed care programs. So that is the Hoosier Care Connect, the HIP program, and then the Hoosier HealthWise program. So as you can see through this graph, we've continued to see some utilization decreases over the month during the emergency periods in this pandemic, getting to kind of a low point during the April timeframe. We have started to see utilization start to increase from that time point, but again, something that we'll have to continue to monitor to see when providers and groups are able to get more to full capacity and where they were previously to the pandemic going into place. So just wanted to kind of give you an overall view of what this looks like graphically from utilization we've been looking at, and we continue to monitor this, and we'll keep an eye on, what this looks like moving forward.
Thank you. Further questions? The maintenance of effort will go away when? December 31st?
Yes. So as long as the enhanced Fmap is in place, the maintenance and effort will have to be in place.
Okay. Representative Porter.
Per our request, thank you for doing the Medicaid forecast. It did drop today, so, but I appreciate it. It would give me some more time to look at this and ask more questions, but I do appreciate the Medicaid update. And I know it dropped this morning on the table, but I wish we could have had it, Mr. Chairman, at least for yesterday, so we can kind of look at it over, even though it's not a whole lot, but some stuff that, some other questions that may have risen and did some more research. So I appreciate it, and I know as we talk about the 6.2% in federal match moving forward for COVID and other emergencies, hopefully we'll be able to work our way out of this situation. And I don't know if the future holds or continue to take Medicaid-related dollars to help backfill the budget for 2021. I mean, I know we have a COVID funding update coming pretty soon, but to me, a lot of this is integrated in regards to Medicaid and this COVID funding, and we look at our whole budget situation. So again, thank you, and I appreciate your report today, and hopefully we can really look at these dollars and address the concerns of individuals that are unemployed, become unemployed, lose their jobs, that may not be, as you said, covered right away, but covered down the road, because I think we're going to have some problems down the road, and when it comes to looking at insurance for individuals here within the state that may not be covered by Medicaid. Thank you.
Thank you. Further questions? Thank you very much, Paul.
You're welcome.
Mr. Johnston, COVID update?
Thank you, Chairman Brown, members of the committee. Good morning. I'm here this morning to provide an update from last month regarding the federal assistance on the public health emergency. If you recall, a couple of meetings ago, we walked through the various cascading of funding from the federal government, and we talked about funding going directly to certain entities, such as individuals, hospitals, community health centers, some directly to communities. Today, I really want to focus mostly on the coronavirus relief fund, but touch on the supplemental funding that does come to or through state agencies. If you recall, when I was here last time, I think there were as many as 3 pages, probably 3 dozen different supplemental grants, which was funding that really comes through existing grant programs. It's just additional funding for this specific purpose. Most of the rules are the same for that funding. However, they may have a focus related to the pandemic. It's close to $1 billion. There haven't been any recent awards from that list. It's out on the SBA website. There was an announcement late last week. I don't believe any of the states have received any of the money yet, but Okra and Housing mentioned that the Community Development Block Grant, there's actually already been two awards of CDBG. It looks like there was going to be a third one as well, but that was just announced by HUD, and I don't believe it's been awarded yet. But relating to the supplemental funding, there has been additional spending. As I mentioned before, because these are existing grants, it took some time to actually get the awards in place. And a lot of times it requires developing a grant application, communicating with the potential participants, getting them to apply for that award. And so there has been increased spending. When I was here before, I think it was approximately $187 million of that $1 billion had been spent or had been drawn down. That's increased $50 million. Spending is about $236 million. The primary drivers of that is the school nutrition program. The draws have started. We talked a little bit about funding that went directly to school corporations in the state of Indiana. So those draws have started, and we're showing up in this month. And then also, Senator Taylor, you had asked about FSSA getting some additional funds other than the Fmap that was just discussed. One of the programs, several programs that FSSA is administering is through the Department of Aging for congregate meals and direct meals and nutrition support services. And so there was additional funding and programming related to that. So those, across the board, most of the supplemental grants have started and are starting to draw those funds, but these were the 3 that really contributed to the $50 million increase in spending. So
I want to talk specifically about the school elementary, secondary school emergency relief fund. I'm hearing from superintendents across the state about the lack of utilization of the funds for testing. Let me tell you what I mean by that. Are there any restrictions that you know of when the schools receive these grants? Is there any restrictions on what they could use the money for?
I don't believe there's a lot of restrictions on it. In fact, if I recall, there are as many as 15 provisions of what it can be used for, and the last one is pretty broad as to whatever is needed to operate the schools safely.
So my concern is twofold then. I hear that some school districts have, and I'd like to check on this, some school districts are using these funds to create a reserve. Does that make sense what I'm saying? Like, let's say Is this a reimbursement scenario?
This program is administered similar to the Title I funding that they get normally, and so whatever those procedures are, they have to follow those procedures. I do believe it's reimbursement. That's why the draws are just starting right now.
So it is reimbursement. I thought Title I was direct grant funding. All right. Under the school nutrition program, that's different. I'm talking about the second one, elementary and emergency relief. Can you find out? Can you get me like a list of what they could spend the money on? All right. All right. Thank you. Thank you, Mr. Chairman.
Senator Brown?
Yes.
To follow up on Senator Taylor's questions, with respect to school nutrition, if a school is alternating in an alternative system like every other day, some of our high schools do that, or the students who have opted for the virtual option but otherwise would have been eligible. I know when all the schools were shut down, the schools in my area, for example, in the spring, did some kind of a outreach for meals for the children families who would have been eligible, whether they went to a central site or they could go to the school during lunchtime and pick up their meals. So is there any restriction, or is anybody counting? I mean, so for example, let's say a third of the students are not in school. Is the school still receiving its full school nutrition dollars?
I believe they are. And so even if they go completely remote learning, the same program that was conducted in the summertime continues. In fact, I think they've made the U.S. Department of Education made a statement to that effect.
So they should be having some outreach, even if it's a 2-week shutdown, or if 30% are virtual and the rest are in school. They should be making sure they are having access.
That's correct.
And just to follow up the second question on the emergency relief fund, so to Senator Taylor's point, Title I, his understanding is not reimbursement, it's grant. You think this relief money is not like that it's reimbursement only?
I believe so. In fact, I think that was on the DOE, state DOE website, on the instructions of how to actually set up the grant and draw the funds.
Okay, so even though there were a few restrictions from what you said, they still have to send a receipt in and be reimbursed for whatever they...
I think they still have to demonstrate that it complies and draw the funds down.
Okay, thank you.
What I'd like to move to next is the Coronavirus Relief Fund. And so that is the allocation of money that went to the states and other eligible entities. What I've put here is a reminder of the rules that have to on which we have to comply. And again, it's necessary expenditures incurred due to the public health emergency, not accounted for in the budget, and have to be costs incurred between March and the end of the calendar year. Revenue replacement is not a permissible use. And the U.S. Treasury and their Inspector General issues guidance. In fact, it continues to this day. The last week of August, the U.S. Treasury sent out guidance, and then within days, the Inspector General sent out its guidance, I think on September 2nd, and caused quite a stir among states and recipients, because there seemed to be conflicts between what the Treasury and the Inspector General was saying, and it's continuing. Everyone is seeking clarifications on some of those matters. The reason I want to bring this up is that the last presentation, I think the last slide, we talked about a lot of the speculation related to federal legislation that was being discussed back in August. And as we probably are all aware, there was a lot of talk, but there hasn't been any action on that. And so I don't have any insight more than you regarding what the next steps may be. Some of the discussion back in August talked about extending the deadline. I mentioned December 30th. There was a lot of discussion about that. That seemed to be the most common theme. There was also discussion about revenue replacement and other features, but what happens next, we'll just have to see. The federal government probably has continuing resolutions that they'll be considering at the end of September. There's some speculation that part of that may incorporate the coronavirus relief fund or the CARES Act funding, but again, we'll have to see. So the next page is similar to what was presented last month, and I'd like to go through a couple of these items. This is the reporting that the OIG requires or has required. They're undergoing a new reporting format, and so I think we will change that up depending on what those requirements are. As I think mentioned last time, the report that was as of June 30th has to get refiled under this new system, and then we will file a report from July 1 through June 30th for this quarter, or excuse me, September 30th this quarter, and that has to be filed within 10 business days, or within 10 days of the following quarter. And so we'll have updated information through September that has to be filed with the federal government. This format, they wanted to present this mostly, the left-hand side is what we've reported in the past. This is updated through August, and in various categories. You see the categories of spend. I'd like to touch on a couple of these. The transfer to other governments is the local program. We've got a Memorandum of Understanding for $300 million with the Indiana Finance Authority to distribute those funds to local governments. To date, that $13 million, or through August, $13 million had been reimbursed to local governments. Let me take a brief minute to talk about that. Very, it's a low number, and we're looking to encourage local units of government to use that money. Part of that, though, is back to this confusion between the Treasury's guidance and the Office of the Inspector General. And it has to do with a provision regarding how to use the money for payroll expenses. And as you can see, and this really ties into the second item, as you can see, not many expenses have been used. At the state, that's the state level. We have decided not to move any money or to reimburse the general fund for these expenses until we receive greater clarification from the federal government. The number that we have there for the commitments is our estimate of those expenses through August 31st, but we have not moved any of that money. And so this, for the same reason, I believe the locals are waiting for that clarification. We're in communication with AIM and AIC on those matters. There will become a point that I do believe the Inspector General, through some communications that they've sent to the National Governors Association, the National Association of State Budget Officers, those trade associations, if you will, that the Inspector General is, I think the word was, trying to align with the guidance that the U.S. Treasury sent out. So hopefully that will be happening, and we'll be able to move forward with some direction, not only at the state level, but on that first item for the local units of government. The public health expenses, we had talked about that a little bit before. A lot of that, the spending, the $181 million, is through the PPE, the Personal Protective Equipment marketplace that the IEDC had set up, and for distribution of those materials to others. And that was primarily the increased spending there. The economic support, there was some increased spending there by about $12 million, $13 million, which we'll talk about here in a second. That was related to the rental assistance that the Housing and Community Development Authority had created. And let me stop there on see if there's any questions on this slide. There's a lot of numbers here.
Yeah, thank you. Thanks, Chris. And I received this, and I'm not sure where it came from. I thought it was part of this package, but it gives the guidance for the September, as of September 2nd. Yes. So I assume that's the Inspector General?
Yes.
And it really, really expands the uses of the money for public employees, police, fire, right?
The,
The September 2nd basically says that,
yes, so you're right, and that's what the conflict is. So they actually identified the class of employee or the type of job that it can
Right.
be used for. Before, they were just labeling it as public safety, but they got into firefighters, they got into police officers and identified. I think that was helpful. But the difference though, the debate right now is presuming whether all of those men and women that provide
Yeah.
those services qualify. Where the Inspector General came down is substantially dedicated, without defining substantially dedicated, and having each entity to go down to the employee level. Not that I can take my entire department, but they had to identify and document that I, as a police officer, made a run and encountered a COVID-stricken person, or, what have you.
well,
So-
the way I read this, and like I said, this is so broad, it says that as an administrative accommodation, the government entity can presume that this employee meets the substantially dedicated test, unless it says otherwise. So this really expands the uses of the CARES money. I understand it's not revenue replacement, but it sure is a broad step. So in allowing a lot more of money to be used for public sector employment costs. So you're saying that the reason that we can't go by this, I didn't get the August one. I only got the September one. So I didn't know there was one in conflict with this. Do you expect this to be resolved in the way that the Inspector General is looking at?
Based on the last 4 months, I'm not going to predict anything.
Okay. All right.
But here's what I think is the forces that are happening, is you have what you're reading, and that is an accommodation. And I think most entities want that accommodation. The Inspector General, which it's sort of like the State Board of Accounts. Fear the Inspector General that comes out to your state and says, give me all your documentation of why you made this decision, has sort of put a little paralysis out there in people's minds. And so what I'm hearing, and we'll see whether this comes true, is that the Inspector General is saying, and people are hoping, they align closer to what you're reading as far as how they are going to interpret this when they come and audit. So,
Okay, so
yes,
my-
I think most everyone is helpful. In fact, all of those trade associations have sent letters, and I think as recently as yesterday, the National Governors Association sent their own letter saying, please come together on a common agreement.
Okay, so we hope that we'll get guidance on this before the end of December, right? So that we
That's
can
correct.
actually spend some more of this money?
That's correct.
And so what you've put in here in your second line there,
Yep.
does that assume that we can use this money?
Yes, it does.
Okay, so this extra, it's almost $100 million from over the last time.
Well, because we're showing it as it accumulates over time.
Right.
So this
Okay.
still is not a projection through the end of the year what the potential is.
Okay.
This is just through August, our estimated payroll through August 31st.
Oh, this extra $100 million is only for the extra
Couple of months.
since June?
Yeah,
Oh.
July and August.
So if we could make this go through December, it could mean a lot of money.
It does, it's substantial, yes.
Yeah, okay, thank you.
So what I'd like to do quickly is, so a lot of these commitments and obligations, our governing document is through a memorandum of understanding with the agencies that are actually administering the program. And so I've listed here those memorandum of understanding. There's others that are still being developed. These are posted out on the SBA website under the COVID-19 link. But quickly, and a lot of these are subsets or features of what was on that spreadsheet that I had just mentioned. So the IFA has the local program. About 322 certifications have received out of a potential of 600 plus. It's all counties and municipalities. A total of now these are more current numbers. These are updated through probably last week. $17 million in reimbursements have been approved to 156 applicants, and their turnaround time is fairly quick, less than 2 weeks. The Indiana Economic Development Corporation, as I mentioned, a lot of their purchase orders and obligations are related to the PPE marketplace that they stood up. They also have the Small Business Restart Program, of which there's been 232 grants for just under $1 million. 49 of those grants have been to minority and women-owned firms for the amount of $175,000. State Department of Health has significant, and this is probably one of the memorandums of understanding that will be amended. We're supporting the stand-up of the testing network and contact tracing. While we have the money, they also have some additional testing grant money that will kick in after the first of the year. But we're sort of standing up the network or helping them with those services, PPE, and then also grants to locals. Last week it was announced the network and having grants with local units, local health departments, and part of this relief fund is being used for that. The Housing and Community Development Authority, as I mentioned, had a rental assistance program. The total obligation or allocation is $40 million. They've spent or sent out about half of that to about 9,000 applications. They still have 10,000 applications in process. In fact, they're using, I forget how many National Guardsmen are helping them process the applications there. The Workforce Ready Cabinet, there was approximately $50 million for their programs. Really, it was augmenting existing successful programs, the Workforce Ready Grant and the Employer Training Grant. And here are some statistics related to that as far as their enrollments and completions and who their partners are. Then the Employer Training Grant. The number of employers and trainees, the average wage there. FSSA, another area is with their providers. We had talked last time about the Division of Aging and the Developmentally Disabled Division, providing some assistance to those services. Again, many of those had to shut down just because of the social distancing and could not provide services. And so there so far have been $14 million of grants that have been awarded to 67 DDARS providers, 31 for the Division of Aging, and then 24 community mental health centers. We're looking at additional providers with FSSA. There may be some supplemental programs through them. And then the Indiana Destination Development Corporation set aside $10 million for a lot of these events and sustaining events, both arts and cultural events that a lot of our communities provide and are really sort of the character and culture of our communities. And those applications were due on September 8th, and they're under review, but I don't have anything to add beyond that.
Senator Brown has a question.
Thank you. I'm not sure you'll be able to, but going back to under the Department of Indiana State Department of Health and their testing and contact tracing.
Yes.
I've received some emails from constituents that they would have signed up to do COVID testing and never did the test and received positive results, and at the same time, some have received testing and actually followed through and received negative results, and then have continued to be contacted by contact tracers.
Okay.
So my question is are the contracts that we have, are they contingent on the number of contacts? I know we were at the time trying to hire up to 500 contact tracers with that contract we put out. But is there work related, is it hourly, or is it by the number of contacts?
Piecemeal, you mean, or as far as the number of contacts?
Yeah, exactly,
Okay.
because that's, on both ends of the spectrum, that's pretty disturbing. So people who are getting positive tests, who've never taken the test, if there's an impact with, now that we're in school, with respect to their children or their workplace, that's a problem. The flip side is, those who tested negative, I don't know why a contact tracer is continuing to contact them repeatedly.
I'll find out and get back to you on that.
Thank you.
I do know that they do a lot of follow-up contacting, because if all of a sudden somebody has to quarantine, they have a whole separate script of working of, do you have enough food, what other resources do you need? And so not just contacting the person, but then if there is a positive case, what other support services are needed? So it's not uncommon for somebody to get contacted a lot. It could be some confusion, along those lines.
Yeah, but then when they're negative, I don't know why. Yeah.
Right.
All right, thanks.
Senator Talian has a question.
Yes, thank you. Final one. So I'm just trying to keep track of where we are since the last budget meeting. And the last budget meeting I had that we had approximately $2.5 billion in money. You'd committed somewhere in the area of $1 billion. Now I've got a number here that says we've received 2.4. And it looks like from this, we've either spent or committed about 1.1.
Through August?
Okay, right. All right, so we still, through August, we've got about 1.3 billion sitting there. Or available.
Available, but I will say that, like, as we talked on that payroll, right, that could be another $300 million for the rest of the year.
Right.
Right.
I get it, yeah.
Yeah.
No, that'd be great, but, so I'm just trying to keep track of that uncommitted amount. We still
Right.
have about 1.3, is that
I would say,
approximately correct?
I would say it's closer to 900 million to $1 billion, because if we get the favorable ruling, we're going to use the payroll expenses.
Okay.
I expect some additional programming through FSSA. There are some other.
But I get
Okay,
it.
okay.
I mean, you're looking into the future of
Well,
where we might spend it. I'm
Right.
just talking about right now.
Yeah.
That's what's there.
Right.
Okay,
Yeah.
thank you, Chris.
Kathy, go ahead. Yeah.
Thank you, Mr. Johnson, for the presentation. I guess I've got a broader question. Back to that, about $1 billion left that hasn't been allocated. That's supposed to be used by the end of the year, really to help make Hoosiers whole through this pandemic, right? And do we have a plan for that $1 billion?
Well, we do. That's where I was talking to Senator Talian about that. There's other programs that are being reviewed. I know the agricultural community, there are some programs that to support some of those entities. The other area that is a lot of things are up in the air, but that is sort of up in the air right now is schools are going through the FEMA process, and there's some confusion about what eligible expenses apply there. And so I do want to hold back, I'm recommending that we hold back some money, that to the extent that FEMA, there's a bottleneck or whatever the reason is, that we could, if they are successful with FEMA, we could still use this money to cover their match. And so that's an appropriate use. So we want to set aside that. But there is some confusion at the FEMA level about what are eligible expenses. And so there are some expenses that could be covered by this relief fund that right now are being called into question at FEMA. So that's something that I don't think we want to short, and so we want to hold that back. So there are certain buckets, that could consume this money.
Okay. Thank you. So to follow up on that, I guess I appreciate that. And, right now we have so many Hoosiers suffering. The last figure I saw on the Star, 313,000 households facing eviction. Food insecurity is epic. Very, very big concern in all of our communities. Energy insecurity. We have different small businesses are closing down in all of our communities, and child care centers, which are kind of the backbone of our working economy, are in a very, very serious crisis. And so I would just like, since we're not really having a public dialogue except for a little bit of conversation at these meetings, I just want to raise up these issues and express my really strong desire to see a plan sooner rather than later. If Hoosiers have some assurance, for example, that they won't be kicked out of their home because that rental assistance is being provided, that not only creates that immediate relief, but the mental relief for our stressed Hoosiers will be very, very significant as well.
Correct.
And we're just kind of waiting to hear. It's now the middle of September. That's 115 days from the end of the year when we have the opportunity to spend these dollars to help Hoosiers now. And I think the more we can help Hoosiers from falling behind significantly, the quicker our economy will be able to rebound from this crisis. So I just wanted to share those thoughts because that's what keeps me up at night.
Yes, appreciate that. You mentioned another area that the IFA has been having discussions with the Township Trustee Association. The eviction, the rental assistance, utilities. That's obviously an area that township trustees provide township assistance on, but we've started discussions with them of trying to understand the demand that they see out there, and is there a way for these funds to potentially support those activities as well. So again, there is a menu, but it's also understanding how many other moratoriums are put in place and what is the effect and all of that, so that we're getting the money where it's having the greatest impact.
Stay tuned. Thank you.
Senator Taylor.
I wanted to ask you about the FEMA match. So schools I make sure I understand. Schools can apply directly to FEMA to get money to assist with what?
Cleaning supplies, personal masks, whatever they need. But
how about testing?
Testing, I don't believe that they can on that. So they're applying as if it was similar to it's a public assistance program similar to a tornado or a flood.
Okay.
There's certain things that they can apply for as a public sector entity.
PPE.
Primarily that.
Right.
Yeah.
So if the schools are relying right now on families to self-report. We know that, right? When a kid gets tested, they don't get a notification at the school, or from what I understand, even the local health department, the kid is tested positive, okay? So the schools are saying, can we test children? First of all, I don't know if they could do it under our current statute, but they are asking whether or not there are funds available to provide testing for students. Has that been discussed by this committee?
The test, I'm not avoiding your question, but this is really a lane that I need to stay out of, and this is really for the Department of Health, Dr. Box. So I know they have been communicating daily or multiple times with schools on many matters, but I'll follow up on the testing component.
Okay. What I'm saying is, can some of this money that we have under the CARES Act be used to...
Well, we're directing a lot of money to testing. I think the issue is, how do the school corporations fit into the network?
So some of the money that you do currently are providing does go to testing.
Oh,
we
yes.
just don't know if we can use that money to
Well,
send
I'm,
to schools for
yeah,
testing.
and I'm not saying that they don't. I just don't know enough of the what they've got, their operations. But, I mean, there's free testing. There's, sites in every, around the state.
Yeah, that's for the general public. I'm talking about okay, so, all right.
I don't know as far as standing up at specific schools. I just don't know enough about the operations to speak
Oh,
to
okay.
that.
I was really asking, is that an eligible expense? But I guess you don't know that.
Testing is an eligible expense.
It is an eligible expense.
That's what I said with the Department of Health.
Okay, all right. But then you go through the Department of Health for that test? Okay.
Yeah.
All right. Thank you.
Just close with, as I mentioned, the new reporting requirements that we'll be following, and it'll be broken down. I think we got a little ahead of the game. It'll be broken down by projects, which is what we sort of have allocated by Memorandum of Understanding, and so we'll do the projects, the obligations, the grants, and expenditures through that. It's quarterly reporting, and right now it's the quarterly reporting through October of 2021.
Representative Porter.
Thank you, Mr. Johnston, for being here again. I'd just like to reiterate some of my concerns that I've had over the last couple of budget hearings. We have $2.24 billion, which we've talked about on several occasions. Right now, this is September 15th, and I think you got local government through your slides. There are about $300 million allocated for that. Only $17 million has been actually spent. Spent $17 million. This is September 15th. Small business restarts, $30 million allocated. According to your chart, it's 960,000 right now. Rental assistance, $40 million allocated, $19.2 million. MBE, WBE, $500,000. You have 49 grants, $175,000. This is September 15th. I just don't see us spending the money, getting the money out the door.
Okay.
And I've raised that with you before, and I raised it here with this chairman and even with the governor. And I don't know what people are anticipating that will happen, but these are real numbers. I mean, this is 60 days out or 75 days out, and this is where we are. I just don't see us be able to get all these dollars out in a timely manner. So I'm just trying to figure out how much money we're going to have left, how much money we might potentially have to revert back to the federal government, or we use the money to help 2022 or 2023 budget. I don't know, but I'm very concerned about these dollars getting out, period.
Well, I share your concern. It's something that we're monitoring daily. On the programs that you had mentioned, I can speak to those. The rental assistance, you mentioned 19 or 20 million out of the 40 million. I'm confident that money will go out the door. It's oversubscribed. There were still the 19 million was based on 9,000 applications. There's still 10,000 applications that they're working through. So at that run rate, that money would be consumed. The local government program, I think, based on our discussion with Senator Talion, we all know that public safety is a large expense to local units of government, and so if we have a favorable coming together between the federal government entities, I'm confident that the $300 million will be claimed primarily for public safety payroll expenses. And then finally, the one area that I think you raised a good point, and the IEDC is looking at that, is the Small Business Restart Program. It was established to try to be complementary to the Paycheck Protection Program and the other federal programs. It has not moved very quickly, and so I've asked them to look at their guidelines, and can we liberalize that to create greater interest in that program.
Thank you.
Thank you very much for the update, very informative and appreciate it. We did have a letter sent out to everybody on committee by the Technical Revenue Update Committee. The state of Indiana, because of the delay in income taxes into July, was some changes in how the numbers were coming in and very volatile over the last 2 months, 2 to 3 months, and will continue to have ups and downs, but more experience going forward. So there's not a consensus that a revenue update at this time will be reliable, and will go on the December revenue update. With that, we're adjourned.
Question. Do we have a date for the next meeting?
What?
Do we have a date for the next meeting?
Yeah, we do. You want, huh?
I will.
Tuesday, October 20th.
All right, I don't have that. Okay, thanks.
Yeah, Tuesday, October 20th.
Excuse me, Mr. Chairman, you move so briskly. Does anyone here know how much money the state has borrowed for unemployment from the federal government?
As of through August, they hadn't borrowed any.
We haven't borrowed anything?
Not through August.
Okay.
Thank you.